Case number 2, a 50-year-old male night manager of a 24-hour convenience store reporting depression to the primary care provider when he comes in. Male, African-American, height is 5'10", he weighs 185 pounds, and he claims that overall he's pretty healthy. He complains of feeling depressed, irritable, agitated, seriously affecting his marital and his work relationship. His work times, 11 p.m. to 7 a.m., 5 days a week, off on weekends. He goes to bed at around 8:30 a.m. when he gets home from work, and he has several awakenings during the sleep. He drinks several cups of coffee each night to help stay awake. The patient's wife complains that he snores loudly on the nights he does not work. His blood pressure is not controlled. It's 145/95, and it is untreated. He's also known to be pre-diabetic. Here are your questions. Question number 1. Which of the following factors contribute to poor sleep quality and sleepiness in shift work disorder? Number 1, work schedule. Number 2, sleep loss. Number 3, individual responses to circadian challenge. Number 4, individual differences in vulnerability to insomnia. Number 5, individual differences in vulnerability to daytime sleepiness. Number 6, all of the above. Make your selection now. Carl, a somewhat difficult question, but the right answer has to do with vulnerabilities to insomnia and daytime sleepiness, doesn't it?
Exactly, and I think, Paul, this is the kind of question where there are many potential right answers, to be fair about it. But there are genetic differences in how people adapt to shift work, to circadian challenges, and admittedly, some people simply cannot work shift work, unfortunately. But unfortunately, in this particular stage of our knowledge from a scientific standpoint, we are not going to be able to identify these folks prospectively. So we have to actually learn strategies to manage their difficulties as optimally as possible.
So is it more his vulnerability to insomnia or more his vulnerability to daytime sleepiness, or both?
I think the data seems to show that even insomnia may have a difference in terms of genetic vulnerability between people. So sleep disorders in general seem to have genetic bases, at least in the case of certain sleep disorders. The other points on this slide, work schedule and sleep loss, naturally, the schedule that somebody engages in can very much determine whether or not they develop a shift work disorder or not. And certainly sleep loss or not sleeping sufficient numbers of hours can eventually contribute as well to shift work problems.
Okay. Question number 2. Which of the following statements is false? Shift work may contribute to the patient's depression, diabetes, and high blood pressure. Number 2, the patient may have obstructive sleep apnea. Number 3, the patient should be advised not to drink coffee while at work. Number 4, the patient should be prescribed S-zopiclone. Again, which is false? Make your selection now. Well, Carl, maybe a little bit of an easier question, but again, which one is false? The patient should be prescribed S-zopiclone. S-zopiclone has a very long half-life. It may not be appropriate for this patient for a sleep time, is it?
Precisely, and certainly the patient who we're suspecting of having sleep apnea syndrome may not necessarily be the optimal choice to give them a hypnotic, which might in some cases make their apnea worse. So I agree that may be something we might want to defer until later on when we know that the patient, for example, has been cleared of sleep apnea.
Well, Carl, you bring up a very important point, which is in this gentleman, we should be suspecting not just that he has shift work disorder, but with his hypertension, pre-diabetes, and his snoring, we really have to think about the possibility that he may have shift work disorder, but also another sleep problem, which is obstructive sleep apnea.
Exactly, highlighted by snoring, daytime sleepiness, and it's a common problem, and it's more common in patients with shift work, possibly related to their sedentary lifestyles and the propensity for weight gain. As you pointed out, we also know that some of the comorbidities that are evident in this particular patient are also very common in shift workers. Cardiovascular disturbances, hypertension, metabolic disturbances, prediabetes, depression, and psychiatric disturbances, and certainly sleep apnea, as we mentioned before.
So in this patient, we really have to think about and rule out obstructive sleep apnea before we give him a medication that could actually make his obstructive sleep apnea worse. So the correct answer, the wrong thing to do, is to prescribe S-zopiclone. So the shift work may contribute to the patient's depression, diabetes, and high blood pressure. That is correct. That is an accurate statement. The patient may have obstructive sleep apnea. That's an accurate statement. And the patient should be advised not to drink coffee while at work. Why is that, Carl?
Well, actually, it may not be such a bad thing to do because, as you know, we know that people at work can benefit from caffeine as a way of enhancing alertness. But I think the point being made by this slide is that that should not be too close to their bedtime, or at least when they leave work.
Excellent point. Question number 3. On the following, which is not necessary when initially assessing the patient's sleep disorder? Number 1, sleep-wake history. Number 2, sleep-wake diary. Number 3, polysomnography. And number 4, Epworth Sleepiness Scale. Make your selection now. So which is not necessary? Carl, we don't really need a polysomnography. We don't need a referral at this stage of the game. We're trying to make a point that getting a good, accurate history should in most cases be sufficient. Isn't that correct?
Precisely, and as we mentioned before, it's this misalignment between their circadian rhythms or sleep-wake rhythm and the environment where they're supposed to be awake but they're asleep and vice versa that really is the key factor which determines shift work disorder. And certainly polysomnography may be appropriate in certain cases, but it certainly will not rule in shift work disorder. It could rule out sleep apnea, narcolepsy, and other disorders which we may want to factor out before we treat a person with shift work disorder if we suspect them. But on the other hand, they won't rule in shift work disorder.
So to make the original diagnosis of shift work disorder, which this gentleman has, we don't need a polysomnography. However, we may want a polysomnography. We may want to refer the patient for sleep testing to rule out obstructive sleep apnea, which at this point seems
A possibility.
in this
Absolutely.
patient. Question number 4. What is the correct ICD-9 code for shift work disorder? Is it number 1, 327.31, number 2, 327.36, number 3, 327.37, number 4, 292.85, or number 5, any of the above are okay? Make your selection now. Carl, this is a tedious question, and sometimes it's difficult for us to remember numbers, but we're trying to make a point here that there is a definite ICD-9 code for shift work disorder, isn't there?
Exactly, and we're trying to be, of course, as you know, as specific as possible when we make diagnostic formulations for patients. And the one that's most specific for shift work sleep disorder, shift work disorder, is number 2, 327.36. I don't recall what the descriptors are for the other codes on the slide. However, there may be insomnia or other disorders noted, but the one that's most specific for the disorder we've been discussing today is number 2.
Okay, just for the audience, the 327.3s are the circadian rhythm misalignment disorders. That includes delayed sleep phase, advanced sleep phase, jet lag, etc. And 327.36 is the one for shift work disorder. Question number 5. Which of the following should be considered when treating this patient? Number 1, naps during the day. Number 2, bright light during work. Number 3, modafinil or armodafinil. Number 4, melatonin. Number 5, all of the above. Make your selection now. Okay, so Carl, this gentleman has shift work disorder, and we've talked at length about the benefits of naps, appropriately timed and appropriate length. We've talked about bright light, how it can be very beneficial in alerting, and of course, darkness during the times when we want somebody to be asleep. We've talked about the fact that modafinil and armodafinil are indicated for the excessive sleepiness of shift work disorder. And we've talked about the fact that melatonin can be effective in helping patients with insomnia with shift work disorder. So really, all these are appropriate, aren't they?
They're appropriate, and I think the other point to be made is that they may be considered in different sequences. So maybe the behavioral methods, as we demonstrated earlier in some of the cases we discussed, might be the first strategy to start with, changing one's lifestyle, sleep hygiene, education, and so on. And secondly, to be able to consider bright light therapy and darkness therapy, if you will. And if these strategies are not helpful, and including napping, if these strategies are not helpful, then maybe considering pharmacologic agents might be the next step.
Excellent.